Good afternoon, everybody. This is Kevin McGinnis from the National Association of State EMS Officials, and this is the Community Paramedicine Insights Forum program for September 2016, also brought to you by the National Organization of State Offices of Rural Health and the Center for Innovation and Research. I want to again thank my partner in crime here, Gary Wingrove, who's with the Paramedic Foundation and Mayo Hospital, for keeping us going. This month it is an audio-only program. We're not going to be doing PowerPoint. The program is being recorded and will be available on the cpif.communityparamedic.org website where you registered. So if you want to have somebody hear this again or view any of the programs we've had for the last 4 or 5 years, you can find them in the archive page on that website. This afternoon, we're pleased to feature a service doing community paramedicine in Minnesota. The service is a for-profit service, which is a more unique, I shouldn't say more unique, I guess that's not appropriate, but one of the relatively few for-profit services working on community paramedicine system building, and also delving into the social and mental health needs of its community. Meds One is in Grand Rapids, Minnesota, and its director, Tim George, is here with us to describe what Meds One has been all about, what Meds One is becoming with community paramedicine in a actually pretty long history of involvement, and its future. So, Tim, welcome to the program, and tell us about Meds One.
Well, first of all, let's talk about, and thank you for having us here for this presentation. Talking about Minnesota and then looking at our agency as a for-profit entity along with our governmental partners that run services, as well as also the nonprofits, facility-based. In Minnesota, the Emergency Medical Services Regulatory Board licenses ambulance services, EMS agencies, based upon geographic areas called primary service areas. And the primary service areas
Hey, Tim,
yes.
I'm sorry to interrupt you. Can you get a little bit closer to your microphone?
Sure. How's that?
That's much better.
Okay. And the primary service area that we cover is about 1,028 square miles, largely in Itasca County. And for the EMS licensing process, we have to have mutual aid agreements with adjacent EMS agencies. So there is no competition, as it were, or no duplication of services within a given primary service area in this state. And with that, for-profit entities like ourselves have a certain leveling of the playing field when it comes to partnership for grants, and also the ability to seek governmental subsidies and funding, similar to some of the adjacent entities that are fire-based ALS services that serve pretty much the most of the northern populated area of northeastern Minnesota. And so we have, again, adjacent partners, no competitive processes. So the for-profit structure, which is a small number of services within the state, serves us well in the areas of gaining other types of funding. Meds One, as I said, has been around since 1978, covers 1,028 square miles of a county that's about 3,000 square miles in size. Of that, about 10% of that is water covered. 1,400 lakes, rivers. The Mississippi River runs through the lower portion right through the center of the community, about 2 blocks away from me. And it is probably about a half a block wide here in this area with a number of reservoirs. Given that, we have a lot of broken country around here with a number of small communities as well as the urban community, which is Grand Rapids, which is the county seat in the center. And we're approximately about 11,000 population with about a 43,000 resident population that we cover for the service area. Our county in this area also has that about 45,000 total. We cover part of another county. That's where we pick up the other population. And then at any one time, we have about 1,000 visitors to about 2/3 of the year. Itasca County in this area in Minnesota is tourism largely, And then technology, we have a lot of technology-based services startups that have settled in here with a fairly highly educated population, good number of the adult population here, undergraduate and graduate, as well as a lot of retired population with early retirement, getting into secondary jobs. And then we also have timber, a lot of timber industry in this area. With that, we have a significant number of governmental entities from Department of Natural Resources, U.S. Forest Service, that are going to serve any of these industries for regulation and support. So it's an interesting area to work. We have a highly educated population and a population that expects service, and a very distant population to serve, especially people that live in the northern portions of the county. Our ambulance service covers the area with advanced life support, population of about, again, 43,000. We have a service crew member size anywhere between 32 and 40, depending upon time of year. About half are paramedic, half EMT. And we run 4 ALS units out of this base of operations in Grand Rapids. In Itasca County, there's another ALS service in Deer River, which is a hospital-based service. We have a community-based basic life support service to our east, about 25 miles, and the northern part of the county is covered by a basic life support volunteer service, and that's probably the least population concentration is in that area. As far as the demographics, taking it over and looking at the number of service calls and responses, 4,000 requests for service, and 1,000 of those being ALS critical care interfacility transfers. The nearest level 2 trauma center that we have is 82 miles away, and we stand at about 2.5 to 3 hours away from the metro area of Minneapolis-St. Paul. And so we cover a good distance in any type of transfers that we take here for any type of tertiary care. With that, we'd like to try to serve the population as close to the community as possible. So when it came to a natural relationship between the services that are in the county and the County Human Service Department, we ended up being requested as, at that time, the only advanced life support service, about 1996, to partner with the new behavioral crisis team that existed just for about 2 years in the county to try to facilitate some assessment at home, out of hospital, that normally was being done in the hospital or the clinics. And there was a significant amount of surge going on at that time as we had our local behavioral health inpatient facility closed, as well as a lot of other adjacent facilities and state hospital system, because of various changes in federal healthcare regulation, reimbursement, as well as also clinical issues with the chronic mental health population. And what we did is we changed a little bit of our approach to non-emergency responses with behavioral health providers. Mental health professionals, mental health providers that were on 24/7 responded to a residence. We'd respond cooperatively with them, and we would do assessments with people that were in behavioral crisis, suicidal ideation, and a wide variety of other behavioral presentations where it came to light that the person needed an assessment. We would do a lot of presumptive lab assessments, very basic blood glucose assessment. We would do urine analysis to determine if there's potential UTI, especially on the senior population. And then just general H&Ps, and then looking at medication compliance. And that rolled in about 1996. With that, we were able to decrease the number of people actually requiring to go to the emergency department or clinic, and we're able to reduce by about 40% at the first couple of years of people requiring, that were in this population in crisis, requiring out-of-county, out-of-community inpatient care. That shifted quite a bit over the last, probably following 10 years, because the recipients of care were getting more complex, as well as the requirement for the pre-assessments were also getting more discrete and complex. The emergency departments here in the state took on the role of actually doing a lot more of these assessments. Still, with that said, we still respond with the crisis intervention team, and then also do follow-ups with the team related to a lot of the non-critical patients and the patients that aren't in behavioral crisis. And a lot of that is related to determining, a lot of our goals there are determining medication compliance and why non-compliance is occurring. And we have strategies that we look at. There's a 9-part strategy process that we look at related to that looks at recognition of factors leading to non-compliance through, why is the relationship possibly strained between the provider and the patient. And in there's a number of technical, some of them very minor things that we do, like trying to get simplification of the medication regimen changed by the provider so that the person can actually, modify their medication intake and medication support and compliance. So with that, moving into about 2011, we started overlapping with something that now we call the Community Paramedicine program. It was community health outreach, where we had specific paramedics, myself included, working with previous relationships that we had developed with home care organizations from hospitals, our health and human services partners, including public health nursing, hospital clinic nursing staff that were doing the scheduling and referrals, primary care providers, and also the military service veterans officer from the county and their staff, to develop a method of taking what we were doing with mental health providers and advancing that to people with chronic mental health issues as well as chronic direct health care concerns. And it was found that probably the better way to work with that would have been to identify the population through a particular central location, and that was the Adult Protective Service Office for the county. And at that time, Adult Protective Service started seeing an increase in the number of reported cases, largely because of awareness, technology, and then an increase in the number of home care agencies that existed that were private, and all the other mandatory vulnerable adult reporters were recognizing an ever-increasing, largely aging population of retired people that have started moving in the area. Odd things that would happen here is that we're a tourist area, that we have quite a few areas that are specific to secondary homes, that people come up here from other states for the summertime, and counterintuitively, given the type of winters we have, they actually decide to keep this residence and get rid of their residence in Indiana and Texas and other parts of the country and stay here. And that proved an interesting result of increased risk to those patients that are, locked in an area where we have to get to with four-wheel drive, sometimes snowmobile, to provide assessment if they have some type of chronic health care condition. And we certainly saw the area seeded with a population like that, as well as the resident population growing and aging. So the Adult Protective Service section of the Itasca County Health and Human Services decided to look at a contract with Health and Human Services for our program. And we had a proven program for the first year from 2011 to 2012, where we actually were able to show that we had a decrease in number of inpatient placements, out-of-home placements, into everywhere from skilled nursing facilities through the lower-level assisted living facilities. And we're able to somehow also get to these residences that people were living in, home care. So home care here, where in other places in the country I'm hearing issues between concern of competition between home care and community paramedicine, we're a kind of a first call entity for a lot of home care companies through human services, where they want to have further evaluation of their client population. Same with the skilled nursing facilities. We supplement assessment for Department of Human Services and Department of Health when there's a complaint in skilled nursing facilities and assisted living facilities related to concerns for care, many times coming from a family member who visits the person, maybe not understanding disease process, et cetera, but sometimes there is a lapse in a care. We work with the team to evaluate the care practices. And I have to say that we've had nothing but a positive relationship with nursing departments, individual nursing personnel, et cetera, when we're doing these type of assessments, and then also educating to try to minimize any type of lapse in care, but also maybe work with them and then other agencies, including county-based home care, through public health to get better care for their patients and compliance with some of the care plans that may have some lapse in them. But overall, our care that we're providing and assessments are one-on-one, and again, largely the adult population. And it could be something as simple as an at-risk individual living alone who has a person that's a relative rather that's living out of the state that only is in contact with their senior grandparent or parent, uncle, aunt, or friend, and they have a concern. They put this through the state system. Minnesota has what's called the MARC system, the Minnesota Adult Abuse Reporting Center, that acts as a clearinghouse, and they simply can call it or you can pull it up on a computer and fill out a request form. That goes to our intake person at the county, and anything that has any potential medical impact or behavioral impact comes to our agency. And then we will either work with a team, probably about 10 to 20% of the time, to respond, including there's a designated sheriff investigator that I work with quite regularly when it comes to financial exploitation concerns. I do the mental status exam and physical health exam, and he looks at the issues related to potential financial exploitation. 90% of the time, trimming down sometimes each month to 80% of the time, we're doing these things alone, these responses alone. And they're typically related to multiple chronic healthcare issues compounded by aging in many cases. Something that we've just started working with now since the last school year cycled through is working with people that have been reported, children that have been reported through child protection as having some type of chronic medical condition, diabetes being one, that have some non-compliance suspected by school nursing or by the neglect people, education neglect people that do investigation for the county. It's a company called Ross Resources. And they act as a independent school district 318 or the other two school districts. They act as consultants. And they'll call us in to do assessments, and then we will work with school nursing as well as social workers and the family to have a better understanding of the disease process that we're looking at. And thus far, I've only worked on 3 cases like this. All were diabetes. And all were 50 miles north of Grand Rapids in a town called Big Fork, which has, again, a community hospital and clinic, but the resources are less. And again, I think the people that were there, all of them lived within 15, 20 miles away from the central community. So it's a large wooded area there in Chippewa National Forest. And so time and distance becomes a huge issue when it comes to gaining the health care. And we make house calls, as we say, and we see people where they live, they work, and that's where their disease process is going to take a risk. As far as that goes, we get our reimbursement on an hourly basis for the care and assessment we provide, plus travel, and then we have reasonable expenses paid by the county through Human Service Department, including mileage to and from the point of care. So each day, Monday through Friday, unless it's a holiday, first thing that I'm doing in the morning is attending an intake meeting with Human Services that includes child and adult protection, and that's where we get our first contact with the patient is through the report that's coming in. And of that, since October 2014 till last week, we had 304 patients that we've looked at. Now, that's not 304 visits. That's 304 individual patients with repeat visits on quite a few. 22 are only traditional CP referrals from clinics. We're finding challenges related to that, related to getting the primary care provider in a privately owned clinic hospital system, nonprofit, as we have, that's the major provider here in town, the Grand Itasca Clinic and Hospital, to actually refer to us. We do have Essentia Health System, which has a small hospital in Deer River. They have been referring patients to us through their system. And those patients are traditional CP referrals in the fact that we're doing assessments to not have the patient come to the emergency department as opposed to having the in-house care and assessment. We're doing wound care assessments in between home care, as well as doing wound cultures and blood draws, EKGs, wide variety of H&P related tasks. And with 14 of those patients that we had came from home health agencies, private home health agencies that requested us to assess their patients on a variety of clinical conditions, and then 268 were from APS investigations. And out of that, one of the things that we're doing is we very, very we scrutinize the cases clearly related to cost savings that we can provide the county. Itasca County has with it medical assistance, is operated through Itasca Medical Care, which is what we call county-based purchase model. And so most of medical assistance actually is run through a county-run insurance agency. About 40% of our Medicare with low-income Medicare is also managed by IM Care. So they have, as we say, a lot of skin in the game when it comes to try to provide cost savings. And we're looking at just this select group of adult protective service patients and the cost from Medicaid data, where we're able to save payers in looking at it about median range, about $5,030 a month just to get somebody into one of the assisted living facilities or lower acuity skilled nursing facilities. And then we apply it to these patients, all the ones that we've kept out looking just at the last month, we're at better than $800,000 cost savings, because it's pennies to provide the home care on the dollar when it comes to this. So counties looking at this, they came up with the assessment model themselves through the auditor's office and treasurer's office. And on a month-to-month basis, we do this assessment, and then we also have a reporting process every 6 months to the County Board and Health and Human Services Board. And along with that, we have a performance assessment improvement system that we use that's based on the Triple Aim framework, if people are familiar with that, about patients, their experience for the care, the improving health of the population, and then reducing the per capita cost of health care. And we've been spot on our targets on those since we started doing that 18 months ago. So that pretty much in a nutshell covers our program, such as it is. Quite a bit different probably than other programs that are out there, but I think, again, as when you see one community paramedic program, you see one community paramedic program. I guess that's the old saying.
Okay, Tim, thank you very much. That was fascinating. I'm going to actually have to listen to this a couple of times because your services are so varied and intertwined. It's just a really neat example of how the services have evolved. And I think one of the messages here is one that we're hearing more and more often in community paramedicine, and that is start small, start with one thing, and once you do that well, then start to meet the increased demands of others to do more and expand your services. And clearly, you've taken on more and more, but managed to keep them manageable. Can you just go over one more time your current sources of revenue? I've heard at least a couple of them, and I think it would benefit listeners to hear again where your revenue is coming from for the CP activities.
Okay, first of all, there's actually funds allocated for referrals through the IM Care program I talked to you about, that I presented rather. Those are the cases where we've only done 22 direct contacts, looking at that time frame from October till 2014 to September. And just as a challenge there is getting the primary care providers to understand what our capabilities are, and we've seen a growth on that. So those are built upon the allowable reimbursement dollars in Minnesota, which is essentially $1 a minute built on 50-minute increments. So $60 an hour. There is no reimbursement for expenses. And so what we've been able to do to offset expenses related to supplies and equipment that's non-durable in those responses is we've been able to work out with the clinic to take everything from vials for lab assessments and tools that they have that are going to be expendable, and they'll lend us that, as well as, if we don't carry Doppler, we carry a lot of gear, but if they want us to do a Doppler assessment, we'll take that out from the clinic and bring it back again. So that's built upon the standard medical assistance reimbursement framework that's been set up when the legislation was passed in Minnesota. The rest of the reimbursement, including when home care requests us, the home care requests us directly through Human Services, that's built upon an hourly rate. And our hourly rate here is $75 an hour, plus reasonable expenses, and then 57 cents a mile transport. And in Itasca County, to get 12 miles, like a lot of very rural areas, is because of all the lakes, we could be going 50 miles easily to get that 12 miles, and they're well aware of, that service cost being in there. So that's the primary reimbursement. Now, the hourly is not direct patient care, though. The hourly is spent on a particular, as we call them, human service case and public health case. So it may well be that I am with a patient an hour, by example, this morning, but I also had to do referral work with a home care entity this morning, and I had to sit in a meeting at Human Services. All of that is reimbursed through Itasca County Health and Human Services General Fund, and they have allocated general funds for special projects. Other than that, we would also occasionally do free service for individuals who can't afford it. If we go out and there's a person that needs care, they don't fit into the APS, Adult Protective Service model, they also don't have the capability of being reimbursed, we do provide that. We like to provide that service through a program called Project Care, which we're affiliated with. It's a 3-site free clinic system, and we provide 2 people from our system within that system as providers. And it's a kind of unique situation where normally I'd have a nurse practitioner, PA, or physician, but there's some nights, especially when weather hits here, that they don't show up or can't show up. They operate from home, and I can get scripts written, prescriptions rather, and orders put in through the hospital. I can do that for labs, et cetera. Those are all free services, and again, in a given situation like that, especially with a person that does not have insurance, doesn't have reimbursement, they typically require a little bit more depth of assessment than can be provided at the residence. And we have a great hospital systems here within the county and the other 2 counties that we have these free clinics at that provide our lab and our x-ray, and then we have models for getting free prescriptions for this. And so we utilize that method for those patients.
That's great. Forgive me if I'm just being a little slow here. I'm just not hearing the words I'm expecting to hear. Is some of your revenue coming from the state legislation for Medicaid reimbursement?
Yeah, okay. And that's where I talked about the county and IM Care. What IM Care does is they manage the MA dollars for most of the medical assistance here, as well as they've purchased like an HMO model. They've purchased about 40% of the lower income Medicare, so we're able to actually tie into that, which is kind of nice. But again, it's not the population that we'd like to see, and we're trying to attempt to grow that. One of the changes that we think that's going to probably benefit us is that our local hospital, the largest facility in the county, is going through a process of partnership with one of the larger systems in the state. And so with that, they're well aware. They've had talks with us already about providing service. And so we'll probably be looking at a higher percentage from those medical assistance dollars. Yeah.
Super. Okay. Gary, I invite your questions and also invite you to open up the line so we can get others in to ask their questions.
All right. I'll unmute everybody's line now.
The conference has been unmuted.
I'll give you first shot. Gary, do you have any questions?
No. Thanks, Tim, for doing this. I think you guys have a unique model, and the engagement you have with your county, especially as a private provider, is awesome.
We're all about partnerships up here, and I think probably Gary knows that because one of the things that we have that's nice to provide coordination when it comes to partnerships like this for public and private is the Blandin Foundation is situated in Grand Rapids.
The conference has been unmuted.
And so given that, that's the leadership process that they've taken on has set the stage and set the tone for this type of partnership. And it exists throughout the governmental and private-public partnership communities here.
Super. Any listeners have questions?
Yeah, this is Pete Carlson down in North Memorial and Robbinsdale, Minnesota as well. Tim, thank you. I learned a lot. I came on a little late, so if I ask a question that you had provided an answer for, I apologize. But of your 304, unique MRNs, just curious, do you have a total visit count just to kind of offer the context of whether or not you're seeing folks twice or 6 times? Or?
Yeah, I do have that. I'm going to pull it up right now. When it comes to, let's just look at the 268 individual patients for the Adult Protective Service. Of those, 106 of those use the service, more than 3 times before. Afterwards, we're looking at about, 48 of those actually. We had multiple follow-ups. So
okay.
The APS usually we can manage, as I always say in human services now, 90% of your time is spent with 10% of your patients and vice versa. Not quite that accurate, but I have a patient and his spouse both have chronic medical conditions that were both reported. In that, I think I've probably seen the female patient prior to her admission, ultimate admission, probably 6 times.
Sure.
And then the visits that they've been authorized for the county is once a month for the male because he lives alone, and they would like to have, and he's really resistant to using clinic services. So they've cleared that. Given that, I've only seen him 3 times. But
right.
As long as he stays here and doesn't move to Florida, he'll, which he's planning on trying to do next year, I'll be seeing him once a month. So, and then they're really, really cooperative with that. It's less costly overall, improves health overall, and it's going to be less costly to the Health and Human Services system ultimately too if he can stay in his residence. So.
Absolutely. So, and then my second question, which kind of ties into that a little bit, is, if you're graduating or discharging a patient, do they have the opportunity to kind of reach out to you again directly? And the second part of that being, is there some centralized kind of 24/7 access call point for all your patients?
Yeah, yes, there is. Human Services would like the patient to use the intake when possible. There's a telephone number. There's always a human service administrator available. However, we, informally, once we've developed these relationships, we try not to cross boundaries and create, ambivalent boundaries there for the system. But we will give contact points, and a lot of times to the sheriff's office, non-emergency line. And that's probably one of the more common ones. If they're receiving any home care services, they have the ability to access us through talking to their home care nurse. And if it's a family member that we've actually made contact with that has some level of connection, not even including guardianship, it doesn't have to be that depth, we just make sure we have, say a son or daughter, we'll ask them to look into reaching out also. So there are definitely the formal processes, which most of the time that's what we're looking at, and then there's the informal. Every time we do an informal connection, though, we run it back through one of 2 entities. One would be the Director of Family and Children's Services or the Head of Public Health. And that way we make sure that they officially put it into their system. In Minnesota, we have something called the SSIS system, and that is connected. That is the ability of any social service and public health provider that's operating from a county and then also DHS can access information on clients. And we'll want to make sure that that request is being, monitored. So that's not something we're doing informally.
Yeah, thank you.
Super. Good to hear your voice again.
Good to hear you here too.
Any other listeners out there have questions?
Hey, this is Rob from Alaska. Do you have an average time on scene or time with client number at all, what the average time commitment is?
The initial intake assessment on average has been running about 90 minutes. That's just, I have better data than that just depending upon the given pathologies there, and I don't have it here to pull it up. But an example would be, I can throw one out that I just recently did, and it was a 75-minute time period, and it was a situation where a spouse actually reported a husband who was having repeated falls, and she was a new spouse and didn't realize that the individual had 2 TBIs in California before moving here and retiring, and then also had some medication concerns with some concern with serotonin syndrome. That was the follow-up with the primary care provider, but the direct was 75 minutes on scene. To get to the residents, interestingly enough, like it would be in probably a lot of areas you cover, it was about equal amount of time to get there and back, a minimum. So we're looking at, easily a couple hours per case, and that would probably be that average. I've had 25 cases that I've done myself. I took several months off over the summer for policy management things and education. I started again on the 2nd, and since the 2nd I've had 25 cases since today that were all new cases. And each one were probably in the 90-minute range on average.
Okay, thank you very much.
Thank you, Rob. Good to hear from you again as well. Any other questions? Okay. Well, I want to thank you, Tim, for being on today. This was certainly a fascinating program, and I wish you best in the future, and perhaps having you back someday to give us an update on where you've gotten to.
Well, I appreciate you being interested and the people out there being interested. And like I said, it's not the average, if there is an average community paramedic program, but again, it has the ability to support itself right now along with the other EMS dollars coming in. But I think that just showing the benefit across the board, both the benefit related to the process improvement plan as well as the impacts financially, that's especially where we're getting our support, because the more we're showing what we're saving, the larger amount of dollars that is actually being committed by the county, and that's every 6 months or so.
All right. Well, I think this has been a wonderful example of exactly the kind of programming that we'd like to continue with. I think that it's beneficial for community paramedicine system builders to hear ideas of folks who have been there for a while and the programs that they've evolved to. So I'd like to just call upon all of you there, if you've heard of an innovative community paramedicine approach, or if there's a program that seems to have established itself well and is moving forward well, please let me know. I'd like to feature it on Community Paramedicine Insights Forum. Our next program will be on October 17th, on Monday again at 3 o'clock Eastern Time. And I would like to again thank Gary Wingrove for partnering in this, and the National Association of State EMS Officials, National Organization of State Office of Rural Health.